Hello?
Good afternoon or good morning, depending on where you are on this beautiful day. This is Wendy Nelson from the Office of Behavioral and Social Sciences Research here at the National Institute of Health. Welcome to the Adherence Research Network's Distinguished Speaker Series. I am absolutely thrilled today to introduce our speaker, who is Hayden Bosworth, who is here from Duke University. Dr. Bosworth is a health services researcher who focuses on patient and organization-level factors to improve treatment adherence. He's the Associate Director of the Center for Health Services Research and Primary Care and a Career Award Scientist at the Durham VA. I think you're going to find that this is just going to be an amazing presentation, and I know you don't want to hear me, so with that, I'm going to switch to Dr. Bosworth. So welcome, everyone.
Thank you, Dr. Nelson, for the opportunity. I'm very thrilled to be here. I'm going to talk about the current state of medication, some of the challenges, some solutions. I'm going to find a way to...
All right, we're having a little difficulty, but... Okay. Do you want to just go to the next one?
Yeah.
Okay.
Thank you. So just the outline, I'll talk a little bit about what the problem is, current policy in the landscape of issues, talk briefly about medication adherence, how do we measure it. I'll talk a little bit about patient-provider communication. I'll add a little bit on mobile health in regards to medication adherence, and then summarize with recommendations. So kind of a whirlwind tour, but I'll try to hit some of the high points go through this afternoon. This is not any surprise, but adherence is a huge issue, and I would argue is probably one of the largest public health problems that we are experiencing.
All guests have been muted.
Determinant of effectiveness. And in general, the prevalence data suggests about 50% of people take the medication as prescribed appropriately. This translates into approximately $300 billion in healthcare costs. And I would also include in that $300 billion, there's patient safety that contributes to that huge number there. I also think, again, in light of the policy issues that I'll mention a little bit, there has been significant changes in the use of generics, and current legislation changes are going to result in a number of people entering the healthcare system and how that will impact medication adherence, particularly about. So it doesn't surprise me anymore that across any disease, any problem, there is always issues regarding adherence. This was an article that was first transplanted hand, and unfortunately the individual wasn't able to adhere to his drug regimen, and the hand, despite it successfully working, was not able to follow the treatment, and they had to remove the hand. We see this in transplants and other various things, and we'll talk a little bit about the challenges, but it's not just the simple chronic disease medications, but it's across multiple areas, and we see problems there with adherence. Thank you. So some of the problems facing payers, if we also put this into the context of policy, is CMS has instituted a 5-star quality system to rate how well pill refill, how we're doing with adherence from the healthcare plan. And the legislation is changing such that by 2014, a 3-star medication advantage plan stands to lose an average of $16 per member, which translates into almost $200 a year. So where there was currently incentives, benefits of immediate pill refill, there will be penalties as we move through 2014. So there's a lot of challenges in the healthcare environment of how do we improve the adherence rates. And I think that's changing the overall landscape and how we're focusing on that. So these motivations are resulting how do we improve these star ratings, how do we increase market opportunities, membership, these quality bonus payments, and then basically how does that result in increased plan profitability. So for those of us who've been doing adherence for a while now, it's early on it was a little challenging because we didn't get as much attention, but with these policy changes that are aligning, a much more focus and interest in these topics are becoming more of an opportunity for us to collaborate and add to. So just quickly, the star rating system, diabetes, the other thing to frame this is that it's diabetes, hypertension, cholesterol, and I think it's really important to highlight why those three drugs for classifications were chosen. Part of it is because those are lower cost medications with a pretty good track record of effectiveness. So a lot of the adherence literature looks at the evaluations are still reasonably inadequate, and I think that's an area that we do need to focus more on. And the sense is that adherence is a proxy, and that even when you have somebody adhering, it doesn't necessarily correlate with good outcomes. So this is where we're starting from. I think there's rooms for us to improve, but if we were to look at, for diabetes here, the PDC is the possession, the proportion of days covered, and you can look at the 1, 2, 3, 4, and 5 star. And so in general, if you're at about 71 to 75%, you're a 3-star, and so the goal is try to move it to a 4-star, which is a slight improvement in adherence defined by pill refill, and then the 5-star. The point, too, is the 5-star is still only at 79% pill refill adherence rate. So it's interesting because there's a disconnect in the literature, because when we look at pill refill, we look at adherence, we arbitrarily define it as 80% or greater. And we were just talking briefly, Dr. Nelson and I and others in the room, that may be adequate for certain drugs, but definitely would not be adequate for HIV or other medications. So again, this is, I think, a way of defining it's where the movement is, but it also does take from a healthcare plan significant changes to go from a 71 to a 75, that 4% improvement in adherence. So just to summarize, I think what the goal of medication adherence is, achieving optimal medication adherence depends on the patient being prescribed the right medication, filling it, and taking it correctly over time. And it requires the appropriate prescribing, effective patient-provider communication, coordination, and active engagement and participation by the patient. There's a lot of pieces there, and it's the point, too, is simply it's just not the patient popping a pill. There's a lot of parts that need to be considered and put into place to ensure that adequate adherence and treatment outcomes are met. Another way to operationalize this is just as a quick schematic that I put together, that if we define adherence in the context of medication, it is a truly complex behavior. So the assumption is you have a problem, you need to make an appointment, you need to accept and believe that there is a need for medication, accept that medication, and then go fill it. Now, right off the bat there, we oftentimes in the literature look at primary non-adherence, and 20 to 25% of people don't even fill the prescription. So when we're looking at the fill rate and then taking the medication and then pill refill, we're usually citing 50%, but I would argue that it's really 50% is assuming you've already filled it and it has already excluded that 25% who may not even take the prescription and filled it. And then this cycle continues, and then returning to the provider for the monitoring and then getting another prescription or refilling it. Now, that's typically one drug. Now, if we times it by 9 or 10 drugs, you can start seeing the complexity and the challenges that may exist. In terms of just medication adherence, again, we were briefly talking before we started and talking about some of the factors that we think are relevant to non-adherence. But if you look across the literature, there have been about over 100 factors at this point that have been identified that have been predictive of non-adherence. So the challenge for us, both in the research environment as well as in the implementation environment, is how do we create programs that improve adherence, but yet can target or tailor despite all these potential factors. So how do we create something that's scalable, that's cost-effective, and then also, I'll come back to this in a moment, but how do you initiate and then maybe create habits and long-term maintenance? And that's something really important, because for many drugs that's beyond acute, we're trying to get people to either take them for long periods of time in the context of cardiovascular drugs or so forth, but and then we also could talk about other drugs where we want to decrease the use of it, pain medications and so forth. I won't talk too much about those types of drugs. I'm talking more in the context generally of chronic long-term medication. So this is just a theoretical framework that helps us justify where are we starting, what are we looking at, and understanding the moving parts there. Again, it's easy to assume that it's the patient characteristics. There's the social cognitive theory where you have to look at the perceived risk and the benefit, understanding those. Cognition, forgetfulness is really a key aspect that most of us will focus on. The other part of cognition is inductive reasoning. So if I wake up at 8 o'clock and I have to take the medication 3 times a day, I have to be able to do the calculations in my head that is 8, and then 8 hours later is 4 o'clock in the afternoon. So being able to do that type of math is important. Literacy, I won't spend too much time on it, but yet 25 to 40% of our primary care setting that we see, at least in our context, are functionally illiterate, which means that they really have a hard time understanding the back of a Tylenol bottle, let alone the handouts that we often give our patients. So literacy is a big issue we need to think about. I'll come to the coping and stress in just a moment, but daily hassles and aggravations really long-term have, I think, huge implications. Side effects are obviously key aspects. Some of our own work, what we find is that allowing patients expectations of what the side effects are and how to handle them can actually be really helpful to alleviate those issues. Mental health, big aspect there, particularly depression, one of the most consistent predictors of non-adherence or depressed individuals. And then comorbidities, the more complex, it's not the number of drugs, it's the complexity of the drugs really have an impact on non-adherence. So those are some of the patient characteristics. Then there's obviously the provider characteristics, which I'll come to in a moment. But communication style, there's a lot of work that the certs are doing in shared decision-making that's really important. Intensity of therapy, there's a lot of work early on in clinical inertia where providers aren't necessarily following guidelines or there's a little bit of slippage. Understanding the medication regimen, I could also probably care coordination, when there's multiple providers involved, how is that all handled? Then there's the policy. I mentioned briefly the CMS 5-star ratings earlier, but there's also the medical environment, the community, and then all this has an impact on treatment adherence. And the important part of all this is that oftentimes adherence isn't really our primary outcome, it's the proxy, and in the end we're trying to really improve outcome. But this is just a framework for us to try to figure out what do we think are the major issues if we were to look at all those factors that have been shown to be related to medication adherence. You'll also notice that I did not put in demographics or social financial aspects. Those are key aspects, but oftentimes those can't modify someone's race or necessarily educational level. So for us, we're looking at modifiable factors. So I want to just briefly, one of the things that were recently just published that I think is kind of exciting, and again, it's good to have this cross-pollination. This is work that initially was we took from the HIV literature, but we just completed a study of post-MI patients who were getting a web-based intervention or a nurse-based intervention with the web. We're still, and I'll come back to some of the data because I think using technology is helpful, but there's some challenges depending upon populations, and I'll show that data. But for this part here, I would just want to, an aspect that we haven't really tapped into a lot, I think, of is chaos. And so with this, we looked at post-MI patients. There were about 400 individuals. They were recruited from 3 main hospitals. And if you look to the left, that 1.07 is life chaos. So this is a adapted measure, but it's addressing questions like I'm always late, there's always something going on, and it's something we can administer relatively quickly, but yet the take-home message is despite putting all these other factors that we would envision into a model, we still find that life chaos is still significantly predictive of outcomes. And I think the important part for us is it's a modifiable factor that we could perhaps look at. So I think it's an interesting topic that we're further exploring, and again, coming from the HIV literature. So just briefly again, we found that 43%, despite having a heart attack recently, reported that they were non-adherent to the cardiovascular medication in the last month, and that independently life chaos was an important factor for non-adherence. So this kind of leads to the issues regarding a medication measures of adherence, and I just want to highlight these. We can use cheap, easy-to-use methods, and then there can be more expensive, relevant, and more reliable measures. And I think there's a place for all of these. The question is what's the question we're asking, who's using it, and what do we need to know? So from a clinical perspective, if I'm just simply as a provider trying to identify whether or not someone's adhering, simply asking them in a non-judgmental way, are you having any problems with your medication? If they say yes, it's a good indicator that there's a problem. But for more complex drugs or where there's concerns that people may not be taking them, we can rely on technology and other various things. But again, costs are issues I think we have to balance, both from the time and the implementation of the devices themselves. And I would argue that we're still grappling with the measurement of adherence. I think the 100-pound gorilla is the pill refill adherence that CMS is using, but I think that in general we really are looking at multiple aspects of adherence when we're measuring it. A paper a junior faculty member published that we were involved with was looking at self-report and pill refill adherence, and the question was, how related are they, or are they actually two distinct behaviors? So just looking at that, if you look at 30-day, 60-day, or 90-day refill relative to a 4-item question that asks, have you been forgetful, are you careless, do you stop when you feel good, do you stop when you feel bad, the kappa statistics are pretty poor, ranging from 0.1 to 0.13. So you could say, well, what am I supposed to do at this point? And so the take-home message is actually both were predictive of blood pressure. So both the pill refill, whether undersupply or oversupply, so oversupply is would be pill hoarding, where you have 120% or greater adherence, and then undersupply would be less than 80%, and then the self-reported were both. So all three were indicative of poor blood pressure in this study. So I think that the take-home message that we argued were they are both important, pill refill and self-report, but they're measuring different aspects of medication adherence. Excuse me. So the other part is, this is a study that Ryan Shaw, who's junior faculty as a postdoc, did with me, where he looked at baseline and then 24-month outcome. And again, the self-reported adherence quickly assessed was a pretty good indicator upwards of 24 months. After 24 months, it was no longer predictive of blood pressure control. And so, I think we have to continuously assess adherence, but, at the end of the day, how frequently do we need to do that? And the data suggests perhaps, on average 6 to 12 months is a good indicator of poor outcome, at least in the context of blood pressure control. And lastly, I just want to, this is an example of a trial that we published earlier, and this was a good example of also the transition from effectiveness to implementation. And so in this trial, among 558 Medicaid patients, we gave our general self-management program, which did have a significant focus on medication adherence, but also addressed issues like alcohol and smoking. But in summary, the adherence rates, using medication possession ratios, went from 55% in the 9 to 12 months prior to the initiation of the program to 77%. This was a quasi-experimental design, and we didn't have a randomization, but when we looked at the comparison of 4,000 individuals who would have been eligible for the program, they stayed consistent at 55%. So just the point is that in general, too, as we do our trials, to think about who the stakeholders are engaging them, and so that we can have these transitions where we can then take our projects and hopefully successfully implement them into the real world. So I want to transition a little bit to where's the role of the clinician and patient and the role of communication. So effective therapies really involve patient adherence and effective disease management. I think patient adherence is one part of the larger self-management issue, and I think I often say that it takes two to tangle at least. So the patient is usually the focal point, but a lot relies on how they interact with the healthcare system, particularly the providers or providers and how they work with them. So I think the patient-centered medication management, this kind of model that we've been moving towards, involves the shared decision-making to reach provider-patient concordance. It doesn't work often at times when a provider just writes a prescription without engaging the patient and seeing where they are, their beliefs of the medication, and their thoughts regarding that. It also assumes that there's effective prescribing by the provider. So are they using evidence-based guidelines, or are they dealing with clinical inertia and really focusing on watching and doing what's appropriate based upon the current guidelines. And then tracking the feedback by the patient, self-monitoring, and then basically the medication-taking behavior. So there's this cyclical fashion that we really need to think about. One of the challenges is, again, as we move from an effectiveness randomized clinical control trial to implementation, is eventually looking at the reimbursement and how do we do all this. It's easier in a research environment, but oftentimes there's a disconnect between what we do in the research and how we get that into the real world. And again, I just keep pointing that out, that I think we need to keep that in mind as we do this type of work. So provider communication, I think, is a really powerful tool that can help improve outcomes in both enhancing patient knowledge, addressing their beliefs, and often also improving satisfaction with treatment. An important thing to keep in mind, too, is that oftentimes multiple studies have shown that patients only recall about 50% of their information that's provided. So we need to think a little bit about how we are conveying this information, and I'll turn shortly to the role of mobile health, but I think that's a particular area where mobile health can be very effective in helping not only recall, but also help reassure and comprehend information, and that this poor patient comprehension recall contributes to unwitting or non-adherence. So some of the collaborative communication is providing clear instructions. Now, this seems pretty obvious, but oftentimes we've heard people say, well, take the medication twice a day. Well, many of us would assume that, well, that means I take it at 8 and I take it 12 hours later, but there is a good proportion of individuals who may interpret it that twice a day is I take 2 pills in the morning and I'm good for the next day. So defining very clearly how the medication should be taken is one important point. I mentioned earlier the side effects and being able to really give the patient some clue of what the expectations are and what to do if you experience these side effects. I think that, really understanding where the patients are, do they want a paternalistic and, being told what to do, or do they really want to involve in shared decision-making? There's a lot of complementary medicine that occurs in that, and we don't look at those things, which have tremendous possibilities of interactions with particular medications. But I think there's also, the data suggests that there's a kind of a misperception, unfortunately, that providers don't want to open these conversations because it may lead to a 20-minute conversation, which with a 15-minute visit is challenging. So a lot of the programs that we've worked on are trying to use and do what we can outside the actual clinic visit, but yet thinking about how reimbursement can be incorporated into that. So again, just needing to measure correctly, consistently, in adequate time frames. So the other part of this is that it's not just adequate to have this initially with the start of a new dosing, or new medication, this needs to reoccur frequently to not only ensure that the person's doing what, but down the road continuing that they're following through. And assessing patients' adherence before making changes. So there's a great body of work that the group at University of Michigan and Eve Kerr and Michelle Heister have done, where they've looked at clinical inertia and medication adherence, and oftentimes that what we see is a poor outcome may not necessarily be patient adherence. It could be attributed to poor clinical inertia. So that's basically providers not being assertive or aggressive enough in treatment, or also getting caught up in other comorbidity issues. So some of our own work right now is looking at pain and hypertension, and so oftentimes a patient will come in, they want to talk about pain, but the blood pressure is a little poor, and you can imagine that, which really gets focused on. So that, again, goes back to the patient-provider negotiating what's discussed and where things are. I mentioned already the expected side effects. Alternative provider support, so not just looking to the physicians, but alternative case managers, social workers, and family are key to a lot of this. So I just want to briefly also put this in a larger context. I think medication adherence, we can define it as perhaps a complex behavior, but I think it ends up being in a larger context of disease management. And so when we're implementing these programs, what we find is that that groups don't want to see silos. They want an all-encompassing platform where issues regarding weight, diet, and medication can be all found simultaneously. Now, that's not necessarily from a research perspective, but as we think about moving these into the real world and implementing them, we need to think of it in the context of the larger context of all the other issues going on. And then again, envisioning that how do we implement these in non-traditional settings outside of the clinic, and how can we do this as easily administered and tailoring to the patient's needs and in the most cost-effective ways of doing it. And then in the context of disease management, looking at multiple behaviors. So just quickly, we've done this across a number of different diseases and different issues, but in general, there's a lot of the same underlying context, whether it's in diabetes or it's in sickle cell. And part of that is patients understanding the risk and the benefit. What is the disease? Why am I taking the medications? What are the risks of doing this? And if I don't do treatment, as well as the risks associated with medication, understanding the side effects, knowing when, if I experience something, what do I do? But again, underlying of that, you can see a lot of common frameworks that can help generalize across multiple behaviors and diseases. So I've already alluded to this. I want to also highlight, I think there's 3 stages to medication adherence. There's the initiation, there's the sustaining, and the behavior maintenance. And I think it's really important to keep all 3 in your mind. And I think there's a lot more work done in initiation and perhaps sustaining, but very little in the maintenance. And so in a trial we recently published in Archives of Internal Medicine. It was a telemedicine project for hypertension. And one of the lessons we learned was that there was a huge proportion of individuals who they measured their blood pressure. They were doing everything that they needed, but we didn't really need to do anything except send them eventually reminders every 6 months because they were following the recommendations. Their blood pressure was in control. There wasn't anything for us to do. And that was approximately about 40% of the population. And so what our goal then eventually translated into is maintaining that behavior. So we kept sending them positive reinforcements, reminding them that they're still in the project. But it was a lesson for us to think about that it wasn't just simply getting the blood pressure under control. Once they were successful, what do we do with those people? I also want to highlight, I think, some of the techniques that are involved with what we're talking about. I don't think that there's going to be one particular mode to improve outcomes in the context of adherence. I think we need to think of almost a toolbox. So our own work has looked at level of motivation, the role of self-efficacy, problem solving, positive and negative framing, cueing, chaining. Cueing and chaining particularly, I give the example, I have to take a particular medication in the evening, and it's just once a day, and drove me nuts. So here I am doing work in adherence, and I be tired at the end of the day and I'd forget to take my medication. So it wasn't until I realized that I needed to brush my teeth before I got into bed because my wife would kick me out of bed with stinky breath. So I put the medication right by the toothbrush. So there can be very simple things that we can do as well as get into really complex things. But anyway, so just also setting realistic goals, action steps, self-reward, rehearsal, cognitive reframing, and shared decision-making. And then one other part I'll cut to at the end is I think behavioral economics are a key growing area that we should think about as well. Just in general, again, focusing on some recommendations regarding maintenance and sustainability. That long-term sustained adherence is oftentimes only attained by a small group of patients, and we just don't have as much work as I think we need to look at to focus on this, and it's an area that hopefully will continue growing further. And we can look to our social psychology colleagues because what we're really trying to do is create habits. So if I could see you all, I would ask you how many of you brush your teeth today, how many of you plan to exercise. We all get into specific habits, and so the goal is at least in the cardiovascular disease medication where there's good efficacy of the drugs, we want to try to create this, that it's just a habit, that if you forget to take your medication, you realize and you feel uncomfortable. It's like patting your wallet or you're realizing your keys are missing. So that's what we're trying to translate to. So again, here just making habits, routinizing ways, and it's forming these habits over time. So one thing too is in terms of the programs, we use terms like tailoring and targeting, and I want to just put this in the larger context of patient-centered care. You move from the left to the right in terms of complexity and effectiveness, I think, but you can get into personalized where it's just simply the name of the person, single characteristics. Targeted, maybe just so that certain groups, older adults, younger adults, may get relevant information. And then we get into individualization and tailoring where we can get not only targeting, but identifying perhaps levels of motivation, beliefs, and when we get more into those levels, we generally see that it's more effective, and we can get to the point now with technology to make those scalable to try to individualize and tailor these programs. So just quickly, a little bit about tailoring. It's collected so that it is dependent upon collecting new data so that you can create and tailor the message. It can be on cultural, personal beliefs, and past behaviors are just some examples. And then, in terms of underuse, we can look at why, if we're targeting underuse, we can look at perhaps contributing factors. If there's poor communication with doctors, mistrust, side effects, concerns, just a couple of examples. And then depending upon if the problem is poor communication, then some of the stuff we've done, for example, would be perhaps role-playing with the individuals. How could they improve those relationships? So if they feel rushed, we can work with them and provide some examples of, entering the room and with a list and saying, here are the 2 things that I'd like to be able to address, and role-playing mistrust in the doctor, some other issues that we've worked on as well. I mentioned the side effects. I just briefly, again, of the overuse, when we talk about adherence, we have to be careful not to only focus on utilizing and increasing utilization. There are areas, particularly for pain medication, that we want to decrease the utilization. So it changes the whole definition of adherence upside down, but it's understanding why there's a greater need for, or perception for the need, history of substance abuse, poor communication with the doctor, and addressing those. So oftentimes, depending upon what we're focusing on, we need to be careful if we're looking at underuse or overuse in the context of adherence, but can tailor the messages to address those issues. I also think I want to just highlight step level of care. I think that you can almost tailor the level of intervention to the dosage of what the patient needs. I mentioned the example of trial where we had a group that were self-monitoring, and they didn't need anything beyond positive reinforcement because they were doing everything that they needed. So, you know, hopefully, and we're seeing this, is that perhaps creating programs and interventions and studying them where, say, 50% get a low-intensive program and then they trigger something that's more intensive, and that may involve some type of nurse case management or higher level of mobile technology. But the goal is that the high-touch, in-person, or pharmacy level, which is more costly, may only be a certain group of individuals. And so our analytics and our analyses need to get better, and there's good data out there that may be able to allow us to utilize that. But our goal, too, is not to wait until the train wreck happens, but can we collect data that identifies who needs to be triaged, if you will, into the different levels. So I think these adaptive designs and trying to create tailoring the right dosage of interventions are going to be really key as we move forward. Just wanted to transition briefly to mobile health. This is probably anybody affiliated with Dr. Nelson in this group. This isn't anything perhaps new, but you know, I think this is fast and furious coming down the pike, and we need to be aware of this and how do we incorporate this into care. But it's not just simply the cost, it's the worldwide use. And from an international perspective, some of the changes that we're seeing are quite remarkable in countries like Africa, areas like Africa and other places where it's almost leapfrogging the web to using the mobile technology. And so how do we create programs to utilize those infrastructure? And I'll talk a little bit about that. But I think at this point right now that in general that, you know, the data is getting better, and some of it has been early on based on small trials. Some of it's from industry. So I think that, you know, the more we push it towards using very good research and methodology will be really key to better understanding what's going on. And the goal is to move this towards scientific evidence, populations of patients, and putting this into the real healthcare system, and considering the reimbursement system. How do we figure out ways to sustain these programs beyond the research environment so we don't get treated or thought as the seagulls where we pop in, utilize our research infrastructure, once the research is done, leave that environment. I think that we need to be mindful of how do we sustain these, and so reimbursement is going to be key. So far, from my look at it, the mHealth trials generally show the best outcomes are when delivered with some human support, whether that's an opportunity for them to click on options to seek additional, if they have any questions, or just knowing that there's somebody behind the technology checking to make sure what's going on. I think that in general the trials are showing reasonably high attrition rates early on, and we're not yet able to see the long-term implications, but hopefully that will continue and we'll be able to look at 6, 12, and 18 and 24 months. But right now we're seeing a decrease in engagement over time, and how do we engage and keep this sticky so that patients stay and individuals use these programs is a key area that we need to focus more on. So I just want to frame, you know, mobile health. We will also have to have realistic expectations of, where it is. You know, I think it's right in the middle between increased reach and efficacy. So again, this goes back to the step level, you know, that we may need phone counseling group programs for certain people that have pretty challenging treatment regimens and could be supported with use of mobile health, but not everyone needs phone counseling and individual visits. And so the mobile health, I think, is a great platform that can help mediate those relationships. But, you know, when we're looking at mobile health, too, again, from a scalability perspective, it's kind of like a public health perspective. Would we expect to see huge changes in blood pressure, for example, or A1Cs? Probably not. But we have to maybe look at it from a public health perspective, particularly if we're trying to frame the cost effectiveness of the return on investment. So again, just to summarize here, so I think it can capture some behavioral and physiological data in real time, which is, I think, really key, and it can be utilized to reduce memory issues and capture longitudinal data. I think that geospatial technology and date and time stamping are kind of really exciting things that we can utilize. So I think, from a research perspective, is creating an environment where we can accept these changes and adapt on the fly, if you will, but doing it in a rigorous way to ensure fidelity. And this is just another schematic of looking at defining how I think mobile health is. And so if you look from the left to the right, patients prompted to capture data, and then data streams collected, transported to the mobile phone. Could look at geocoding, time stamp, self-report, so pain measurements for individuals with asthma associated with what pollen counts and other things like that. So trying to really take advantage of perhaps environmental issues, and then processing these and looking at trends and patterns over time, and then analyzing and visualizing these feedback. So another example that we could use is obtaining blood pressure values, trying to remind them to do it periodically, and then we've created algorithms that if we get 3 values in a 2-week period of time, and those are above a certain value, we can use those to actually make changes to medication. But it works in a research environment. We also have to, at some point, work through some of the HIPAA and the FDA regulations on where mobile is and how we define them. This is also some work from our group. Ryan Shaw was part of his dissertation. I think just as it's understanding the frequency and timing of mobile health, and this may be not new to anybody, but understanding how do we convey that information, what's the appropriate dose, when do we send it, how frequently. And so for a trial he had done on weight loss that was just published in the American Journal of Medicine, what he found was that approximately 1 message per day at 8 a.m. was the most ideal time for most successful for weight loss and outcomes. So just presenting that as well. But I think we have to be cautious of the technology. Again, back to a prior study that I was mentioning before, it's called Sprite, and it's a post-MI patients of about 400 individuals. We had about 30% were African American, 28% were reporting inadequate income, and about 61 was the age. These were all individuals who agreed to participate in the study. They all had heart attacks recently, and they all had to have accessibility to technology, web, or computers. And despite that, 66% reported interest in using a website to email the doctor. 66% would share their health information with family members. Only about a quarter were interested in using a website to send blood sugar data to their doctor, and 18% were interested in reading or tracking their health conditions. I think that these data are, translates to those who are using the computer more. There's better outcomes, whether A1C, LDL, or total cholesterol, but as well as blood pressure. But I think point 2 is that some of our older, sicker people are less likely to be using the mobile technology, and so I think what we're looking at is a platform so that it's not just simply a phone app. It's inter-voice recognition or other ways. And Gary Bennett, a colleague of mine, has done a nice job of looking at weight loss and the control, the self-efficacy of feeling like you can control or decide which mode of administration was very successful in resulting in positive weight loss. And so, at the end of the day, for those of us in research, we're really hopefully focusing on the content where the technology is just part of the tools that we're using, because the technology is going to continue changing. The content and getting it right is I think, the essential aspect of that. So in terms of just some recommendations, some clinical issues to think about, I mentioned this before, just depends upon what your goals are, but if you're quickly trying to assess whether or not someone's having a problem, this is a question we've used before. Have you missed any pills in the last week? Has a reasonable, the sensitivity is not great, but the specificity is fine. So at the end of the day, if they say yes, they're having a problem, you can pretty much rest assured that there's something you need to do. Common misperceptions should be anticipated and avoided, and this may seem like a no-brainer, but I use the example of the time my son was 6 years old and asked me what the birds and the bees were. And for anybody who has kids, it's one of those things that, you prepare yourself, but you're not necessarily ready for at 6 years old to answer that question. Fortunately, my wife is smarter than I am, and she said, before you answer that question, why don't you ask him what he knows already? And so when I asked him that, he said, well, I was reading something about Winnie the Pooh, and there was birds and the bees, and it was completely off base of where I was. And so, it's really important to see where the patients are, what their thoughts are, before we just start the whole rigmarole of giving information. And so I could have emotionally scarred myself as well as perhaps my 6-year-old if I didn't stop and do that. So these are some just quick things to consider as we're moving forward. Missing appointments, if someone doesn't show up to have that conversation with you, there's no way you can have talk about adherence. So particularly if you're looking in the psychiatric realm, oftentimes we have to titrate the medication. It's not that we can just simply prescribe and get it right out of the bat. So I think there's some real important key reminders or clues that there's a problem and we may need to think about it. Technology or appointment reminders, these are inter-voice IVR is a quick way of getting this, and we can do this. Technology, mobile again. 90% of all text messages are opened in 30 minutes or less, so I think that's an important thing for us to consider. And again, the scalability of using that is pretty, can be very powerful. Sorry. So I just want to highlight, I think education and knowledge are important, but those won't by themselves change behavior. And so again, I use the concrete examples. So people have to have a fundamental level of knowledge to make informed decisions, but that's not going to get us over the finish line. We also have to be mindful of the ways we present information. Again, instructions should be clear and structured, and picture charts, color-coded. So cognitive psychologists have done a lot of work in how do we present information, and I think we really need to take better use of those. And then there's also industry where they have done a nice job of doing printouts that represent patients' medications and or additive information that can be provided to the patients. If you envision, you come in, you see the doctor or the pharmacist, you get your prescription, you get your drug, and then you go, and then you don't see them for 30 to 90 days, we need to be able to have something that's a quick reference to help identify that. I think the other thing is pill reminders and blister packages. Those are some other technology that's coming out that I think could be potentially low-cost ways of helping individuals to remind to take the medication. Literacy is always an underlying issue that we have to be mindful of. And then again, some just behavioral aspects, identifying potential relapse into old behavior, setting appropriate realistic goals, simplifying regimens. These are very straightforward, nothing probably rocket science here, but they can accumulate and have large effects. And reinforcing positive behaviors. I think that sometimes that, again, goes back to the maintenance issue that we need to not forget people who are doing okay and ensure that they continue to do the right thing. And then just quickly, operant conditioning and behavioral economics are important aspects. A lot of work now is being done in this area where whether it's incentivizing with financial reimbursement or decreasing co-payments, and I think that it's really important work, but again, I think it falls within the larger context of the multiple things that we need to use to move and improve adherence. So in summary, medication adherence is a significant but complex problem, and while I focus mainly on the patient and a little bit on the provider, there are multiple levels from the healthcare provider and the policy that we need to keep. The times are changing. The policy landscapes and incentives for ensuring medication adherence are changing. Data coming out looking at what happens if you actually provide medication for free. What is that outcome? Those types of things need to continue going forward. I think those are important. Improving collaboration around medication adherence. So the CERT's movement towards shared decision making is going to be key in that area. And again, still not forgetting understanding the mechanisms and contributing factors to medication adherence. I feel like in some ways if you look at healthcare disparities, there's really three levels. There's the kind of the descriptive studies where I think we've done a good job of showing adherence is poor, and across diseases and medications we see that there's some variability. But we have enough to do Cochrane reviews and meta-analyses. I think we've done a reasonable job of understanding some of the mechanisms, but I hopefully have conveyed that I think it's not one mechanism. There's likely to be multiple mechanisms depending upon the individual. Where we really need to focus on is, I think, trying and examining the interventions, parsing out what's working, and then how do we implement that into the real world. And that I think is where the new future lies for us. And lastly, some other things. One size doesn't fit all, so whether it's step level or creating the toolbox with different methods to improve outcomes for individuals, I think we need to continue looking at alternative methods of implementing interventions. So peers, I didn't really focus on that, but in certain communities that can be very helpful and beneficial. It doesn't necessarily always have to be a pharmacist. I think technology is really going to be key, but I worry that if we get caught up in the newest gadgets, it may not really get us to where we need. So I think it's not the panacea, but it's definitely part of the toolbox. We really need to do a better job of costing and looking at these programs, and I think better identifying who the right programs are so that we can better utilize limited resources in the healthcare system. Methods for reimbursement. So how do we incentivize providers to have who only have 15 minutes to see a patient to engage in medication reconciliation? Where does that happen? Who's going to cover that? And those are some policy issues that we need to continue. I've harped on the initiation and maintaining of adherence. I think those are really important. And then considering the multi-levels already. And I think lastly, we always need to consider stakeholders. So while we can't do everything at once, it's really important to identify who the stakeholders are and engaging them not at the end but at the very beginning so that we avoid these long drawn-out periods. And so I think movements like the PCORI are really key to engage and learn how to do that with the stakeholders, and particularly the patients, which is a challenge as well. How do we engage patients as the stakeholders? We have questions. Okay. And lastly, just some of the challenges. Just separating the wheat from the chaff. There's a lot of work out there. Some of it's on the industry side, so how do we really separate the wheat from the chaff and determine what's working, the scalability, ROI, sustainability, and ensuring that we're doing a good job of evaluating what we're doing. So I'll stop for some questions.
All right. Thank you, Dr. Bosworth. I think this has been a really interesting and important webinar. We do have some questions from the audience, and if you have questions, you can do us on Twitter, #NIHadherence. It should be on the screen, or email them to me at nilsenwj@od.nih.gov. But we have some questions from the audience, and both of these are regimen questions. So in reference to HIV that you talked about, one of our listeners said the regimen simplification, such as 1 pill a day in HIV, is helpful for improving adherence, as you noted. But alternative, like a twice a day, often improves the outcomes, the tolerability, the long-term effects. While the single pill option receives great marketing, promotion, and messaging, how do we really communicate to patients which is the best option for them?
That's a great question, and so I'm going to now, for the future, try to incorporate that into any presentation. There is always that challenge and perhaps oversimplifying things. What we see the data is that when you go to 3 or 4 drugs, there's a huge precipitous drop in adherence. There isn't that big of a difference between once a day and twice a day, And if you looked at medication for osteoarthritis when it's once a month, we also have some problems where people forget. So there's this optimal level, and I would say that twice a day is probably in the ballpark because you're not necessarily having to interrupt your daily schedule to take those medications. So, and that goes back to the communication. So if you're the provider, to have that communication, say I can provide you an easier medication, but the effectiveness is not necessarily going to be as good as twice a day. And I think these are some of the challenges. Warfarin, for example, the new drugs coming out. So warfarin, it's been the treatment for 50 years, and we have these new drugs that are supposed to be easier once a day, and we don't know if that's necessarily going to be the right outcome, and we need to continue looking at it. So, so I think, just to summarize, I think twice is generally not as problematic as 3 or 4, and it also goes back to the patient-provider communication and having those discussions.
Great. And we have another question about regimen in terms of factors like color, like the color of pills, the swallowability of pills, the size. What do we know about factors, the tangible factors in medication adherence? Do we know anything about that?
I personally haven't done much work in that, but my look at the literature is that definitely has some challenges. We've also, from diabetes and insulin, I mean, God, patients want to, any opportunity to avoid having to start insulin is a big issue. So that's injection, so it's slightly different. So the formulation of the drugs, I'm sure, and the swallowing is always going to be a problem, and I don't have a quick solution for that. But again, having good communications with the provider, oftentimes there are alternatives, and maybe there are some solutions or ways of addressing those concerns or problems if those exist. But again, it goes back to identifying that clearly is a problem and figuring out a way to resolve that.
Great. We had a message too. It said, "What about tasting kids?" And obviously, context matters.
Yeah. Well, so it's interesting because that's where I think the CVS and the pharmacies, our local pharmacy will charge $10 to put bubblegum flavor in amoxicillin. So anybody's trying to get a kid to take their medication, the challenges of it. It tastes disgusting. And there's a business model where they actually get a little bit of extra money to do that. And we've also looked at packaging as well. So taking your medication, putting it in blister packaging, and so that you have multiple drugs in those blister packages. We don't know what the cost effectiveness is, but the local retail pharmacists are going to have to figure out what their business model is, and maybe those examples where you're kind of almost a specialty pharmacy trying to address the size of the pills, the flavor of the pills, or that older adult parent who's on so many drugs, having somebody help them, and not the wife or the parent, the child doing the medication pill reminders, because we also, just because we see it consistently, that doesn't necessarily mean that they're putting the medications in the right pill box correctly either. So maybe that's where a role of pharmacists could be.
Okay, great. And we had one last question. I know we were all very interested in your ideas about life chaos, but one of our listeners was asking, how is that modifiable? Can you give a concrete example?
So, so I think it's more modifiable than social demographic factors like race. I think that that where we could do it is providing some strategies on how to reduce the chaos. So, looking to a mental health therapist and things along those lines. Trying to simplify life a little bit. I don't mean to be superficial, but I think there's a little bit more room to address those issues than some of the typical demographic factors. So, again, this comes from the HIV literature, and there has been examples where when people are struggling with mental health and all the other issues and getting to appointment scheduling and those challenges, it's helping to facilitate that. The role of social workers could be really very beneficial. So, so I think at a minimum at this point, we're looking at it as a key factor for a risk factor, but trying to perhaps circle back with social workers and others. But I'd be please, offline, if you have suggestions or other things, this is an area that we're just starting to look at that I think will be important.
All right. Well, thank you very much. I know we all really appreciated that. That was Dr. Hayden Bosworth from Duke University, and we thank you again from joining the NIH Office of Behavioral and Social Sciences Research Distinguished Speaker Series in Adherence. So thank you very much. Have a great day, and we'll talk to you next month. Thank you.